Carpenter. I'd like to thank you for taking the time to join me on this video. Today's video is about the physical examination procedures for 3 conditions around the knee. We're going to investigate patellar instability, laxity of the medial collateral ligament, and then finally chondromalacia patella. And these are all conditions for which the AMA guides provide for permanent impairment. So let's begin with patellar instability. And to begin our physical examination for patellar instability, let's diagram out a couple of the key landmarks on the knee that we'll be referring to throughout the course of the physical examination. So key landmarks around the knee are going to include the inferior pole of the patella, the superior pole of the patella, the tibial tubercle, and the lateral aspect of the lateral femoral condyle, which is right through here. Okay, so we're going to begin our physical examination with simply an inspection of the knee. So what would be some of the things that we would want to inspect for? Well, we're going to inspect the knee for any signs of the cardinal indicators of inflammation, which would include redness, swelling, tightness, enlargement of the knee. And on this particular knee, we don't see any of those signs of inflammation. We want to look around the knee to see if there's any distension of any of the bursa in and around the knee. And as you know, there's the prepatellar bursa here, there's an infrapatellar bursa here, there's popliteal bursa, and there's many bursa in and around the knee. And we don't actually see any inflammation of the bursa. We want to inspect for the alignment of the patella as it sits within the trochlear groove. The patella can be subluxed either laterally most commonly or occasionally even medially. So just as the knee sits here, we see that the patella is sitting pretty well situated within the trochlear groove. We also want to make an assessment for the tone of the vastus medialis muscle. And so we can assess the tone of the vastus medialis muscle by asking the examinee to forcibly straighten her knee. And we observe the vastus medialis muscle right here that has apparently good tone. Okay, so then from the inspection we want to move on then to palpation. What would we want to palpate for? Well, some of the same things that we were inspecting for. We want to look for any of the cardinal signs of inflammation, any signs of bursitis. And it's interesting, when you think about the cardinal signs of inflammation, which of those signs are inspectable or visible, and which of those signs are palpable? Well, one of the palpable signs of inflammation would be warmth, also known as calor. So we're going to palpate around looking for any signs of warmth or heat coming from the joint. We're going to look for any palpable swelling that would indicate that there's bursitis. We're going to palpate for any areas of point tenderness, particularly over the medial aspect of the knee, and especially in the region of the medial patellofemoral ligament here, which we'll go into more with physical exam in a minute. And then we also palpate for the tone of the vastus medialis muscle. And in this particular examinee, with palpation, she denies or does not report any areas of pain. There's no visible jump sign or withdrawal reflex, and so I can conclude, at least with this knee, that there's no particular areas of pain or tenderness. Okay, so that's inspection and palpation. After we've completed those 2 procedures, there are a couple of measurements that we want to obtain in relationship to the assessment of patellar instability. The first measurement of concern is the measurement of the Q angle, and we'll demonstrate the Q angle measurement here in just a moment. And then the second measurement of concern is a calculation of the Insall ratio, Insall, I-N-S-A-L-L ratio, which is used for the assessment of patella alta versus patella baja. So let's demonstrate the measurements for the Q angle and for the Insall ratio. Now, to measure the Q angle, you're going to need a protractor, and I have the protractor here. And the Q angle is measured by drawing a line through the center of the patella, extending upward through the anterior superior iliac spine, which creates an angle in line with this arm of the protractor. Then the lower measurement is obtained by drawing a line between the center of the patella and the tibial tubercle here. Okay, so let's make that measurement. Okay, and if you can see, our measurement comes in at 12 degrees. Now, normal Q angle measurement in males is 8 to 12 degrees. Normal measurement for female, 12 to 15 degrees. An increased Q angle beyond 15 degrees in female, for example 18 degrees, would be indicative or suggestive of a high probability for patellar instability. On this examinee, our angle measures in at 12, which is within normal limits. Okay, so that is the Q angle measurement. Let's do the Insall ratio measurement. Now, to make the Insall ratio, you're going to need a tape measure. Now, a little philosophy on the Insall ratio. The Insall ratio is calculated by dividing the length of the patella tendon into the length of the patella, and that gives us a ratio. Now, normally the height of the patella and the length of the patellar tendon should be the same. So if they have the same measurement, what would the Insall ratio be? Well, the ratio would be 1.0. Now, anatomy texts differ in their latitude on the Insall ratio. Some anatomy references state that a 20% differential in the length of the patellar tendon, either shorter patellar tendon or longer patellar tendon, is within normal limits. Other anatomy references say that the length of the patellar tendon can be within 1 centimeter, either shorter or taller than the height of the patella, and to be considered within normal limits. So let's find out the Insall ratio in this examinee. So the patellar tendon is measured from the tibial tubercle to the inferior pole of the patella, and let's put a little relaxation in that. You okay? Okay, so our measurement from the tibial tubercle here to the inferior pole of the patella here is 55 millimeters. From 1 millimeter to 6.5 or 65 millimeters is 55 millimeters. And then the height of the patella is measured from the inferior pole of the patella to the superior pole of the patella, which is 66 millimeters minus our 1 millimeter here is 55 millimeters. So in this perfect specimen, this examinee, the ratio is 1.0. Now, when the length of the patellar tendon starts to exceed the height of the patella, that predisposes to patella alta, which would create an unstable patella and contribute to patellar instability. But on this examinee, the ratio is within normal limits. Okay, so those are our measurements. The next thing we want to consider on the physical exam is range of motion. Now, a couple of considerations on range of motion. Normal range of motion of the knee is from 0 degrees to 135 degrees of knee flexion. 0 degrees of knee flexion indicates that the knee is in full extension. And then we look for 135 degrees of knee flexion. So a couple considerations. One would be is if the knee goes into hyperextension, meaning we get a negative angle of knee flexion, that is a sign of ligamentous laxity around the knee. We refer to that as genu recurvatum. That's a sign of ligamentous laxity, and it could indicate a generalized condition for the particular examinee. And that's going to be important because ligamentous laxity can predispose an examinee to patellar instability. It's most commonly found in young females. So we want to check for the hyperextensibility of the knee. And then secondly, as the knee goes through its range of motion, we want to palpate the knee for any sign of crepitus coming from underneath the kneecap, which would indicate a pathologic condition of the kneecap itself. Okay, so let's do our range of motion measurement. And for range of motion measurement, you'll need a protractor. And we'll ask the examinee to fully straighten and forcibly straighten out the knee. And we'll make our measurement with the protractor. And we see that the extension angle is 0. Okay? Now let's just assess for hyperextensibility of the knee by doing some overpressure here. And we notice that the knee comes to a firm stop and indeed does not extend beyond more than minus 10 degrees, and hers is actually closer to minus 5 degrees when this is not being jostled. Okay, so that is the extension measurement. Let's measure the flexion angle now. And we're going to bend the knee, so you might want to lean back. Normal range of motion of knee flexion is 135 degrees. So we'll bring it all the way up. And you can see that she has obviously more than 135 degrees. She has, well, actually she has right at 135 degrees. So that's a normal range of motion measurement. Then we just want to palpate the patella as the knee goes through range of motion, palpating for any crepitus. And I'll move it. Good. And there is no palpable crepitus here on this knee. Okay, so we did palpation, we did inspection, we did some measurements, we did range of motion testing. Then we want to proceed on to a couple of different orthopedic exam maneuvers. The first of which is the SAGE sign, S-A-G-E, the SAGE sign. Now, with regards to the SAGE sign, the philosophy of the SAGE sign is that normally the patella has some normal movement medially and laterally within the trochlear groove of the femur. And typically the patella can move up to 50% of its width medially and laterally in the trochlear groove. So let's assess for sage sign in this examinee, and we'll do that by drawing a couple of landmarks on the patella. Okay, so if this is the patella right here, and you can see the patella moving underneath my fingers, if we draw a line down the exact center of the patella, that divides the patella into 50% of its width. This is the medial 50%, this is the lateral 50%. Well, if we divide that in half, this is 25%, this is 25 to 50%, this is 50 to 75%, this is 75 to 100% of the width. Okay, now normally the patella can move 50%, meaning that this line can move over to the medial epicondyle or over to the lateral epicondyle and be considered within normal limits. So let's move this over here now. I'll keep my finger on the medial epicondyle here, and let's just slide this over. And what do you estimate that is? I estimate that is about 25% of the width over the medial epicondyle. Some might argue that it's a little bit more, but it's certainly not more than 50. Let's go laterally. Okay, here's our landmarks. Let's go laterally with the patella. And what do you estimate that as? Our landmark has been obliterated under here through movement of the skin, but the landmark is right here, the lateral epicondyle. Here's the midline of the patella. Let's move that over. And notice the patella moves underneath the skin, and I estimate that at about 40% of the width sticking over the lateral epicondyle now. This is considered within normal limits, and what's interesting to know is that the examinee does not have any pain response or does not demonstrate any type of apprehension. So we would call that a normal sage sign. And it's interesting that the sage sign actually has built into it an apprehension maneuver, which is the next maneuver that we want to talk about. The apprehension maneuver is actually built in to the sage maneuver. Now, with the apprehension maneuver, we are going to attempt to simulate a subluxation or a dislocation of the patella. And with the apprehension maneuver, if the patella pens subluxation or pens dislocation, the examinee will tell us. And how will the examinee tell us? Well, the examinee will demonstrate what is referred to in the literature as the apprehension sign. So let's think about this. What would an apprehension sign look like with a bona fide examinee? With an examinee with bona fide patellar instability, how would an apprehension sign look? Now, I know you're all familiar with the apprehension sign. You've probably seen this in textbooks that demonstrate the examinee to get a look of apprehension on his face, sort of, you know. Examinee goes, yeah. But this is not a true apprehension sign. It's part of the apprehension sign. But what the apprehension sign is the apprehension sign is a form of the flexor withdrawal reflex. It's an evasive action. It's a withdrawal. It's a repositioning by the examinee to realign the patella within the trochlear groove. it's involuntary, it's reflexive, it's automatic, and in that sense it qualifies as a true objective finding. So that's what we're looking for with the apprehension sign. We're looking for more than just a look of apprehension on the examinee's face. We're looking for reflexive action around the knee. What would reflexive action include? Well, it would include a reflex contraction of the quadricep muscles to reposition the patella within the trochlear groove. Okay, so let's demonstrate the apprehension maneuver. Now with the apprehension maneuver, we attempt to sublux or dislocate the patella laterally within the trochlear groove. And we're assuming if we're dealing with injured workers and doing qualified medical evaluations, that this is a person who has already had a subluxation or dislocation of the patella, and now they have recurrent instability of the patella. So we attempt to reproduce the lateral dislocation of the patella, and you can see the patella moving here within the trochlear groove. Now, with overpressure and a bona fide attempt to sublux the patella, in the case of true instability, what would the examinee do? The examinee is going to tighten the quadricep muscles, especially the vastus medialis, for the purpose of realigning the patella. That would constitute a true objective finding for the apprehension sign. What else might the examinee do if this was pending an actual dislocation? She might straighten her leg through contraction of the quadricep. She might reach down and grab my hand. She might say, "Oh, stop." She might wiggle in such a way as to reposition her own patella within the trochlear groove. And that would constitute true objective findings for the apprehension sign. And that's a recurring theme that you want to remember with all physical examination maneuvers. You want to look for the true objective finding, much more than simply the examinee's subjective report of pain. You want to look for the true objective finding. Okay, so finally, to complete our physical examination for the assessment of patellar instability, we want to take a routine series of x-rays. And for patellar instability, the routine series includes the AP, the lateral, the sunrise projection, and then also the intercondylar view. So that's the physical examination procedure for patellar instability. This is Dr. Perry Carpenter. I look forward to being with you on future videos. And for now, I'm wishing you best of success.